Episode 15, Strong but Struggling, Clinical Perspectives on Body Image in Sport. Welcome to Case Studies in Sports Medicine. I review published case studies in sports medicine for learners of all levels. Today's case, Mrs. I, a 30-year-old communications professional and recreational bodybuilder in a committed relationship, presented for evaluation. She appeared to lead a balanced, health-conscious lifestyle. She trains 6 to 8 hours a week, alternating weightlifting and cardio, follows a structured workout plan, and maintains a body mass index within the normal range. From adolescence onward, Mrs. I lived under constant scrutiny about weight and physical appearance from parents, peers, and later from herself. There was a history of bullying in her adolescence related to her weight. This early pressure became a backdrop for an escalating fixation on body image. In high school, she turned to restrictive dieting and intense running, even competing in half marathons. Despite visible changes, satisfaction never followed. As she transitioned into weightlifting, the pursuit of the ideal body intensified. Under one coach, she adopted a strict ketogenic diet, eliminating nearly all carbohydrates and fats while training heavily. The consequences were notable: amenorrhea, severe fatigue, and disrupted hunger signals. When the rigid diet inevitably slipped, she experienced dramatic rebound weight gain, deepening her sense of failure. Medical evaluations brought unsatisfactory answers, and I'd like to quote the authors. Several medical consultations were deemed inconclusive as to her state of health, as were biological examinations which failed to identify the cause of her overall ill-being, with the exception of a thyroid hormone level in the lower range of normal. That's the end of the quote. Psychological help was attempted twice but never continued. The search for control, certainty, and body transformation pushed her toward a more dangerous path. Self-medication with performance-enhancing drugs, clenbuterol, and thyroid supplementation, taken over multiple 12-week cycles. She paired these with an array of legal supplements. Mrs. I spends around 4 hours a day immersed in fitspiration and thinspiration content on social media. She frequently posts food-focused images on her social media. She idolizes fitness models and constantly checks her own body, daily weighing, body fat measurements, scrutinizing skin and muscle tone. Meals revolve around calorie counting, and social outings are limited because of food anxiety. With that as background, my differential diagnosis included obsessive compulsive disorder, body dysmorphic disorder, generalized anxiety disorder. I'd like to recognize the authors. This is from a case study published by Cuadrado and colleagues in the journal Psychiatry Research Case Reports from 2024. I'm Scott Hall, a primary care sports medicine physician, and I'm studying for my sports medicine recertification exam in 2026 and hope you'll join me on the journey. This podcast is for educational purposes only. Back to our case, the authors identified a clear theme: a life dominated by intrusive thoughts about body image, diet, and performance, leading to significant emotional distress and real impairment of daily functioning. What started as a desire to be healthy evolved into a cycle of restriction, overtraining, medical uncertainty, and risky self-experimentation. This was amplified by social media and long-standing insecurities. A structured treatment plan was implemented. Medical follow-up was initiated with her family physician to address fatigue, evaluate the effects of her doping agents, and monitor her overall health. An endocrinology consultation was initiated to guide hormonal recovery after discontinuing thyroid hormones and clenbuterol. Psychotherapy to address muscle dysmorphia, dysfunctional eating patterns, and problematic exercise habits with deep self-rooted self-esteem issues was also pursued. She engaged in sports psychology sessions to help rebuild a healthier, balanced relationship with physical activity. As therapy progressed, the clinicians identified long-standing rigid beliefs tied to self-worth and body image. Techniques such as mirror exposure therapy, mindfulness, and sessions reframing sport as a tool for health helped Miss I challenge and change these patterns. Gradually, she began to reshape her self-perception and loosen the grip of impossible aesthetic standards. So, the diagnosis here was body dysmorphic disorder, and I want to describe the DSM-5 criteria for body dysmorphic disorder. Patients experience preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or only slightly observable to others. Affected patients perform repetitive behaviors. The thought preoccupation causes clinically significant distress or impairment in a major life area of functioning. An eating disorder does not better explain the thought preoccupation. Now, in our case, there was a specifier, so muscle dysmorphia. This specifier is used when an individual is preoccupied with the idea that their body build is too small or insufficiently muscular. This is the most common in males and can be applied even if the person is also concerned with other body areas. Next clinical pearl, screen for muscle dysmorphia in athletes, particularly those with physique-focused sports using validated tools like the Muscle Dysmorphic Disorder Inventory. The estimated prevalence ranges from approximately 6% in university students to as high as 44% in male weightlifters. Importantly, muscle dysmorphia symptoms are particularly prevalent in competitive bodybuilders, with some studies reporting rates as high as 53%. Clinical pearl number 3. Cognitive behavioral therapy is the primary treatment modality for muscle dysmorphia. Recent randomized controlled trial evidence demonstrates that a 12-week manualized CBT protocol significantly reduces muscle dysmorphia symptoms, with improvements sustained at 3-month follow-up. In another study, an 8-week telehealth CBT program also showed large reduction in symptoms. Okay, jumping to some practice questions. A 22-year-old male competitive bodybuilder presents to your sports medicine clinic. He trains 3 hours daily, follows a strict high-protein diet, and reports significant distress that his body is too small despite having 8% body fat and visible muscle definition. He avoids social situations where he might need to remove his shirt and frequently checks his appearance in mirrors. According to the DSM-5 criteria, which of the following is the most accurate classification for this presentation? A, anorexia nervosa, restricting type. B, body dysmorphic disorder with muscle dysmorphia specifier. C, obsessive compulsive disorder. D, avoidant personality disorder. E, generalized anxiety disorder. The answer here, body dysmorphic disorder with the dysmorphia specifier. Next question. List sports or activities that place athletes at elevated risk for muscle dysmorphia. Bodybuilding, wrestling, powerlifting, football, or other sports that accentuate physique, weight, or strength. Last question. Which psychological traits commonly found in athletes may exacerbate muscle dysmorphia risk? Perfectionism, competitiveness, need for control, low self-esteem, neuroticism, and anxiety. Thank you.